Mann. I facilitate the blocks for first and second years medical students at Case and have done so for the past 5 or 6 years, seeing this process evolve. The purpose of today's discussion is to familiarize anyone who is not acquainted with the process of clinical reasoning, or who's never seen it, or has only a casual acquaintance with it, so as to enable facilitators and those supervising these sessions to know what's expected, or what to ask for, or what to think of as you go through this. What is clinical reasoning? It's a systematic approach to a very large volume of data, which consists of facts, figures, and stories, so big that it can't be comprehended or amassed or understood without some kind of approach. No approach means, in general, chaos. An organized approach means that we will be following some line of thinking, right or wrong, in error or not, that gets us through the exercise of trying to figure out what it is in this case that's important. In that sense, it's a detective story with clues in the beginning, and upon which there will be elaborations and more information flowing later, which enable the student and the facilitator to refine their thinking as the process goes along. This is a process. It is the doing of looking at and evaluating importance order and subject matter in the history, physical, and tests of a patient that we're going to use that's most important. So those things that are very important rise high, and those that are not so important don't get thrown out, they just drop to the bottom of the list. This process is dictated by a highly elaborate, comprehensive view of a medical science, which can be summarized either in the index to a medical textbook or by the mnemonic vitamin C. That mnemonic covers the major categories of disease, including vascular, infectious, trauma, autoimmune, metabolic, idiopathic, neoplastic, and congenital. And we pass that to students to think of the idea that this will give you everything that could possibly occur in the disease. And if we look at the patient as to where they have what's wrong, fits in under that category or those buckets, then we have a good start as to figuring out what's wrong. The process that follows the elaboration of the buckets or major disease categories that were established in the first part of this exercise is dictated by a very rigid formula for problem solving and disease analytics. In that order is the history, part of which we've already heard, which gave us the buckets. And the history will be a narrative. We're allowed to embellish it by asking questions, and if they aren't provided, we want to ask those things when the chance comes later in the exam. What more do we need to know about this? So these are the elements of the detective story. The most important part is the story, the account of the disease, how long it's been there, what has helped it and hurt it, and so forth. The next step, which follows logically and without exception, is a physical exam, which elaborates and denies or asserts those findings that were present in the establishment of buckets or disease categories. And the last piece is ancillary studies. This is x-rays, blood studies, all kinds of radiographic findings, and so on. These are tests. They confirm what we established by the history and physical. They do not work backwards. One can't go from ancillaries back to the disease in general. True enough, there are patients who come in with their only history is that they have an abnormal chest x-ray, and there's a whole differential diagnosis of that. But when you're dealing with the usual clinical setting where there's a story, a physical exam, the last piece is those tests that we want to do to further investigate this. And students should come up with those tests and what they expect to find. And here again, we want very specifics, not just blood work or blood count. We want to know, is it hemoglobin, is it white count? And not just chemistries. We want to know, is it electrolytes, is it calcium, and is it toxicology? Okay, which of the toxins are you looking for? Inevitably, there's a tendency for people to rush to a final diagnosis. In other words, get to the end of the process before the beginning. That's appealing to problem solvers and to students, but it overturns the whole process of figuring it out, thinking it through, and arriving at a diagnosis rather than just producing one. So the diagnosis-specific response derails the whole process. For example, when someone comes up with a peptic ulcer as an explanation for abdominal pain, we're off the tracks. For one thing, peptic ulcer is the end of the road, not the beginning, and it's an example of, say, infectious disease, which it so happens affects the stomach. Students will have trouble finding categories and examples thereof to fill in the vitamin C or the buckets, but with 4, 5, 6, or 7 people, maybe 8 participating in this, they'll come up with various topics and various examples. And they don't even need to be correct, and the facilitator or person overseeing this doesn't even need to know necessarily that they're important or off or on key. What the facilitator needs to do is make sure that students are thinking and discussing among themselves what they're going to consider in the case. It should go about 5 minutes, but no more than 10. And if there's a roadblock and nothing's happening and there's only like 1 or 2 items suggested, the facilitator would say, well, is that all? And if you get a blank stare, then in fact that is all, and later we'll find out that it wasn't a very comprehensive way to approach the case. The use of buckets or the vitamin C mnemonic will then direct a student to the next phase in the discovery process, namely the physical exam. The findings on examination, even if there are no findings, will be confirmatory or will reject various of the considerations we've already looked at. So there'll be examples of diseases that are dispensed with because the physical findings tell us something else, or those that will be confirmed. In other words, it's a refinement of the original conceptions about the disease, enable us to narrow in on the final diagnosis and narrow also the detective story into very specifics. So when we move to a case with abdominal pain and somebody says, well, we're going to do an abdominal exam, that's not sufficient. We want to know what the student is looking for, which abdominal organs, what are the physical findings, what do they mean, to what organs are the surface, does the surface of the abdominal cavity refer. In other words, think through this beyond just quote, exam, unquote. And the same thing applies to the so-called neuro exam when someone has a headache or is confused. We want to know which part of the nervous system they're interested in and why. And hopefully some of the findings that would indicate something about the case. So this again is put before the student before the case actually surfaces, but it arms the student to look for very specific things and to think about them and direct their attention to those things and not be distracted by other parts of the exam, knowing what they're looking for very specifically. Otherwise, the student gets lost, or any physician gets lost in a medley of findings that don't relate to the diagnosis that we're searching for or the diagnosis we're trying to eliminate. In other words, you can't put this information together in a kind of a stew. It has to be ordered as to progression. There are some set of clinical circumstances that don't lend themselves to this process elaborated here because the complaints or the findings are too disparate and they can't be put together. For example, a person comes in after an injury with perhaps a fracture, also has a fever and has a history of cancer. That's going to be a tough one to fit into buckets. So what one does in those circumstances is list each of those items as something that has to be attended to as we solve the problem. In other words, every step we take will have to relate to these things in the problem list as we go through it. And then we jump to the second phase, which is more historical information, and then the third phase, which is physical examination, and then the last phase is testing. So if people are up against a brick wall because they can't relate these things, then one says, okay, what are the important things that we want to keep in mind as we go through this process, and we'll just list them. And as we're going through the process, we will reject or deny or relate these findings and questions and answers to the problem list and decide which are the important things to look at the problem list and which are the less important ones. In summary, I'm proposing a way of approaching large masses of data for students, typically on Monday when the planning takes place. The more accurate and incisive and intense that planning is, the more logically the case will flow on Wednesday and Friday. And the less orderly and logical it is, the more disorganized Wednesday and Friday will be, because you'll then be setting your strategy and organizing the case while you're doing it. That happens all the time, but we like to get our ducks in line before we undertake that. To summarize even further, it's buckets or vitamin C, the systematic approach. The process is important. Things that we find to look at then are then examined in further historical information and confirmed or denied in a physical examination and ancillary testing in that order and in no other order. If that order is overturned, then the process of finding in a logical way gets derailed. The physical exam that follows should be directed to the organ system or systems, including such often forgot things as vital signs and what one expects to or hopes to find and what it means. And then when cases don't lend themselves to this, we have a list to follow, and we will just make that list and work through further historical information, a directed physical examination, and tests. This being kind of the default mode, but one that works just as well when the case is full of what looks like unrelated facts.